Hello, this is Dr. Barbara Burton. Welcome to this program on MPS disorders, which is designed to review the new research on these conditions presented this year at the 2020 WORLDSymposium in Orlando. The WORLDSymposium is an annual conference focused on lysosomal storage diseases with an international attendance. It's a 4-day event held every February, and this year there were 446 poster presentations and 84 oral presentations, all focused on lysosomal conditions. Let's just begin with a review of the Mucopolysaccharidoses, or MPS disorders. This is a subgroup of the lysosomal storage disorders. All of the conditions in this group are genetically determined disorders in which mutations in different genes lead to abnormal accumulation of complex carbohydrates called mucopolysaccharides or glycosaminoglycans. There are a variety of different subtypes of MPS disorders, and each of the subtypes may also be caused by several different enzyme deficiencies and therefore several different genetic defects. These are multi-organ system diseases that affect many parts of the body, but many have striking skeletal features. They may or may not be associated with behavioral or cognitive disabilities. The major mucopolysaccharidoses are shown on this slide. MPS 1 is the first, related to a deficiency of iduronidase. And in its severe form, it's referred to as Hurler syndrome, although we do see patients with more attenuated forms of MPS 1 that don't have the Hurler phenotype. Treatment for the Hurler phenotype is by hematopoietic stem cell transplantation. ERT, or enzyme replacement therapy, is often used before and in some cases after transplant, and of course symptomatic or supportive care is very important, not just for this condition but for all of the other MPS disorders as well. MPS 2 is also referred to as Hunter syndrome. This is the only X-linked disorder on the list, all the rest being autosomal recessive. Enzyme replacement therapy is available for MPS 2. MPS 3, or Sanfilippo syndrome, is primarily a neurologic disorder with fewer somatic manifestations than the first two. At this point, we do not have an FDA-approved therapy for Sanfilippo syndrome, so therapy currently is symptomatic and supportive. MPS 4, or Morquio syndrome, can be caused by two different genetic defects. We have enzyme replacement therapy for Morquio A, related to GAL-NS deficiency. MPS 6, or meritolame, is related to an aryl sulfatase B deficiency. It is exclusively a somatic disease with no CNS involvement, and we do have enzyme replacement therapy again. And then the least common of the MPS disorders, MPS 7, or SLY syndrome, is a condition for which we also, despite its rarity, fortunately have enzyme replacement therapy. Go into a discussion of some of the research that was presented this year at the World meeting, starting with several presentations related to MPS disorders in general. The first addressed MPS and reproduction through a questionnaire study focusing both on the menstrual cycle and whether there were abnormalities, and also on pregnancy. The women who had answered the questionnaire did show somewhat more abnormalities in terms of menstruation, but the difference from controls was not statistically significant. 6 women were reported with MPS disorders who had successful pregnancies. And we do know from other research that this certainly is possible, although because of the skeletal changes, cesarean section delivery may be more common. MPS comorbidities were the focus of a presentation from Spain, looking at hydrocephalus specifically. They reported that this can be difficult to diagnose. It was reported in 12 patients with MPS disorders, 10 with MPS 2, 1 with MPS 6, and 1 with MPS 7. And they speculated that this goes undiagnosed in many cases because patients may have difficulty reporting the symptoms, because macrocephaly may be a component of the condition even in the absence of hydrocephalus. And so they really focused on the need for increased awareness of this as a complication of these disorders. Point out some highlights of a presentation from Manchester, United Kingdom, from a study done of patients who are now adults but had undergone hematopoietic stem cell transplantation as young children for the treatment of Hurler syndrome, or MPS 1. The question was, does transplant improve ambulation? We know it improves cognitive outcome, but this was looking at a different type of outcome. What they found was that of these 15 patients, 10 regularly used a wheelchair, 9 were able to perform a 6-minute walk test, while 6 were unable to do so. And in many cases, I think virtually every case, the difficulties were related to orthopedic issues. You can see on the right side of the slide that the patients had had multiple orthopedic interventions, hip surgery, tibial surgery, 8 plates insertions, spinal fusion, and so on. So skeletal disease remains a significant issue even in successfully transplanted patients. Berlina in Italy addressed the question of newborn screening in MPS 1, something that's of great interest. They screened over 120,000 babies and identified 2 babies with MPS 1. Both were started on enzyme replacement therapy within 15 days of birth. The patients one of the patients had what was reported to be Hurler to Hurler-Shea phenotype at the severe end, but not clearly a Hurler phenotype. The other was homozygous for severe mutations and did receive transplant in addition to ERT at 6 months of age. Importantly, both patients, who are now 2.5 and 1.5 years of age, show no clinical signs of MPS 1. Really underscoring the success of newborn screening in early identification and in optimizing treatment outcome. Moving on to MPS 2, there was a study from Spain of enzyme replacement therapy looking retrospectively at the impact of ERT in 42 patients. And what they found was reduced urine gags, decreased liver spleen size, increased 6-minute walk test, increased forced vital capacity, so improved pulmonary function, reduced left ventricular mass index, and reduced mortality. All findings that underscore the fact that enzyme replacement therapy is effective in treating the somatic manifestations of MPS 2. More highlights related to MPS 2. This is a very important study from Okayama in Tokyo, Japan, looking at an investigational agent, an investigational enzyme replacement therapy that is designed to be able to cross the blood-brain barrier. It is an idursulfase enzyme fused to an antibody to the transferrin receptor. So the transferrin receptor is utilized as a mechanism to get the enzyme across the blood-brain barrier. A 52-week phase 3 study is underway in Japan to assess the safety and efficacy of this treatment, and preliminary data were reported at 26 weeks at the conference. This showed that heparan sulfate concentrations in the CSF were decreased at week 26, indicating that the enzyme is getting into the central nervous system. Cognitive function and adaptive behavior remained stable, although this is short-term follow-up, or were improved in some cases. There were some mild to moderate infusion-related reactions, but no other serious safety issues. So the conclusion was that intravenous administration of this investigational JR141 product was well tolerated and thus far appears to be efficacious in treating both the CNS and the systemic features of MPS II. There was a late-breaking abstract also on MPS II from Maria Escolar in Pittsburgh related to the Regenix Bio gene therapy directed into the CNS in patients with MPS II, with some preliminary positive results in several patients treated. Moving on to MPS III or Sanfilippo syndrome, where we currently have no FDA-approved therapy, it's encouraging that there are several different gene therapy programs in clinical trials currently. Frits Weiberg from the Netherlands reported very early findings of a phase 2-3 study of AAV mediated gene therapy in Sanfilippo type A. Up to 20 patients are expected to be enrolled by mid-2020, and the data really, are not adequate at present to draw any firm conclusions. Kevin Flanagan from Nationwide Children's Hospital in Ohio reported on the study sponsored by Abeona Therapeutics of an AAV9 based vector carrying the deficient enzyme in Sanfilippo A again into the brain. They have had 14 patients enrolled across 3 dosing levels in a phase 1-2 study, and there appears to be a dose-dependent reduction of CSF heparan sulfate levels, with levels approaching normal in the highest dose cohort. So very clear evidence that the vector is getting into the central nervous system and metabolizing the substrate. The highest dose patients who were very young at the time of dosing thus far show normal progression of cognitive function, although it is still fairly short-term follow-up, but it is certainly encouraging that in these very young patients, thus far, it appears that cognitive function is being maintained. There was also a report in Sanfilippo syndrome type B with a different enzymatic defect, again from a gene therapy trial at Nationwide Children's Hospital with a very similar vector to the one used in the Sanfilippo A trial, except that obviously it's carrying the enzyme, the gene for the enzyme in Sanfilippo B, the NAGLU enzyme. 6 patients have thus far been enrolled in that trial, and the preliminary data show a sustained reduction in CSF heparan sulfate levels and reduction in liver size, showing it works both in the brain and somatically with a good safety profile. It's really too early to have any data addressing the impact on cognitive function. Moving on to MPS IV or Morquio syndrome, data were reported from the registry called the MARS registry, Morquio A registry study, both on the long-term efficacy of treatment with enzyme replacement therapy in the real-world setting as opposed to in a clinical trial, and on the real-world safety. There are 325 patients in the registry, 262 of them on ERT. with some of those patients having come from the clinical trials. Those are referred to as cohort 1, and some having been patients who were naive at the time of their entry into the registry, so newly started on the enzyme replacement therapy after FDA approval. And you can see that across all of the efficacy parameters, 6-minute walk test, FEV1, and so forth, shown there, we see improvements both in the patients who were continuing on therapy, having already been treated in the clinical trials, and in the newly treated patients. Somewhat more dramatic improvement in the newly treated patients, as you would expect, since the others had already received some treatment. And then down at the bottom, a very significant reduction in the substrate, the urinary keratan sulfate concentration in both groups. There were adverse events, of course, and some serious adverse events, but generally the safety profile was one that was certainly acceptable. Moving on to MPS 7 or SLY syndrome, our least common MPS disorder. 2 long-term ERT studies were reported representing extension trials from the original clinical trials. There was 1 study of children less than 5 years of age, 8 patients treated with ERT who had completed 48 weeks of therapy and continued for up to 2.6 years in an extension study. The efficacy and safety are shown here. There was a substantial decline in urine gags. There was increased growth. Hepatomegaly was resolved. Splenomegaly was resolved. And the safety issue was acceptable. The most common safety events were the things that you would typically see in young children: infections. 100% of patients developed anti-drug antibodies, but there was no clear relationship between these antibodies and efficacy, and no one discontinued treatment. In the second study of patients 8 to 25 years of age, all completed a 48-week study and continued up to 144 weeks in an open label study, and they showed sustained urinary gag reductions and positive multi-domain responses in 1 or more of pulmonary function, motor function, joint range of motion, mobility, and visual acuity. They experienced reduced fatigue, and most adverse events were mild to moderate with no treatment discontinuation due to adverse events. So in summary, the MPS disorders are a subset of the lysosomal storage disorders. Each has its unique challenges and clinical outcomes that need to be addressed. Current treatment options are effective, and there are a number of investigational treatments in develop that show additional promise, particularly for addressing the central nervous system aspects of these very serious disorders.